Welcome back to This Week in Pulmonary and Critical Care Medicine. If you're coming off a busy week of service, this episode is built to be practical. One high-stakes ICU trial that tries to solve a problem we all feel at the bedside. One cystic fibrosis feasibility trial that challenges a long-standing routine. And then a physiology-driven review to tighten how we think when the ventilator and the patient are out of sync. The through line is effort. When we replace a muscle's natural workload with machines or routines, what happens to function, outcomes, and safety? And when physiology gets messy, especially on the ventilator, how do we see the problem early and adjust without guessing? Let's start in the ICU, where the cost of prolonged ventilation is paid in complications, weakness, and time we don't have. Difficulty weaning is one of those ICU slow burns that quietly drives complications. Patients meet readiness criteria, fail again, and drift into prolonged ventilation, often with a diaphragm that's simply not doing enough work to stay healthy. That's the premise behind Rescue 3. If diaphragm dysfunction is part of the bottleneck, can we actively train the diaphragm while the patient is still ventilated? Published in the Blue Journal, Rescue 3 was an international, multi-center, open-label, randomized trial enrolling adults ventilated for more than 96 hours who met readiness to wean criteria and had failed at least 2 weaning attempts. Patients were randomized to standard care versus twice-daily transvenous diaphragm neurostimulation delivered through a specially configured central venous catheter system. The trial stopped early at the first interim analysis because of slow enrollment and financial considerations, which matters because early stopping tends to inflate apparent benefit and leaves uncertainty around harms. Still, the dataset is not tiny. The modified intent-to-treat population included 216 patients, 102 in the treatment arm and 114 in the control arm. By day 30, 71 out of 102, or 70%, in the treatment group versus 69 out of 114, or 61%, in control were successfully weaned, with an adjusted hazard ratio of 1.34 and 95% credible interval of 1.01 to 1.78, and a posterior probability of superiority of 97.9%. That combination, credible interval barely clearing 1.0, but posterior probability very high, signals how much the Bayesian framework and borrowed prior information are doing here, and why clinicians should read this as promising rather than settled. In a Bayesian trial, the result reflects both the data collected in this study and prior assumptions built into the analysis. The credible interval just barely clears 1.0, which tells us the observed effect is modest and close to no difference. The very high posterior probability of superiority sounds stronger, but it reflects how the prior information and the trial data combine. In a study that stopped early and has a relatively small sample, that prior influence matters more. So while the signal is encouraging, it's not the same as a large, unequivocal treatment effect. It's a reason to be interested, not to declare the question closed. A second signal was time on the ventilator. On the results page, the authors report a median adjusted difference of minus 2.5 days in duration of mechanical ventilation to successful weaning, or day 30, with a 95% credible interval minus 5.0 to 0.1, and posterior probability 97.1%. That interval brushing up against 0 tells you the effect could be modest, but again, the posterior leans strongly toward benefit. Mechanistically, they also report improved inspiratory muscle strength. Maximum inspiratory pressure increased more with treatment, with an adjusted difference of 5.9 centimeters of water. The uncomfortable question is whether around 6 centimeters H2O separation is enough to plausibly drive the clinical differences, or whether we're also seeing softer effects, more attention, more protocol adherence, and an unblinded environment nudging weaning behavior. The accompanying editorial explicitly raises that concern and argues the physiological delta may feel small relative to the outcome gap. Safety is where the tell it like it is part lands. Serious adverse events were more frequent, 36% in treatment versus 24% in control, and the editorial notes cardiac severe adverse events were higher, 11% versus 2%, and that 2 deaths were possibly device/procedure related. Mortality at day 30 was similar numerically, 9.8% versus 10.5%, with an adjusted hazard ratio 0.74, credible interval 0.37 to 1.46. So we don't get a clean reassurance there. The practical takeaway? This is a credible early signal that targeted diaphragm activation might accelerate liberation in difficult-to-wean patients. But it's not a green light for broad adoption without tighter safety definition, clearer subgroup benefit, and ideally a design that reduces bias. If the ICU trial asked whether we can reactivate a failing diaphragm with technology, the cystic fibrosis trial asks a more patient-facing question. Can we simplify care without losing control of disease? Airway clearance techniques are foundational in CF, but they're time-consuming and the burden is real. Many patients already intuitively trade airway clearance for exercise on days they feel better, but intuition isn't evidence. Published in Thorax this month, the EXACT CF study was a dual-site randomized pilot feasibility trial testing whether exercise as an airway clearance technique could replace usual chest physiotherapy, at least in stable patients on highly effective modulator therapy. They recruited 50 people with CF aged more than or equal to 10 years with FEV 1 more than or equal to 40% predicted, stable on elexacaftor, tezacaftor, ivacaftor, and randomized 48 people to either daily EXACT, which basically means stopping other airway clearance techniques, or usual care. The intervention was practical by design. More than 20 minutes of aerobic exercise, enough to be out of breath, with huffing and coughing embedded before and after sessions. Feasibility was the main target. They approached 117, randomized 48, and retained 45 out of the 48 to completion. Adherence, defined as doing airway clearance on at least 5 days per week, landed at 60% overall, which is not a win, but it's honest and clinically believable. In feasibility trials, that real-world friction is actually valuable because it tells you what a definitive trial will be up against. On safety signals over 28 days, lung physiology did not worsen. Lung clearance index in usual care changed from 8.3 to 8.5 with a mean difference of 0.2, while EXACT changed from 7.9 to 7.8 with a mean difference of minus 0.1. FEV1 moved in the right direction. Usual care showed a drop of 0.8% predicted, while EXACT showed an increase of 2.1% predicted. The authors report an absolute between-group difference in FEV1 change of 3.2% predicted, with 95% confidence intervals between minus 0.6 and 6.9, and a relative difference for lung clearance index of 0.97. Those are the right kinds of signals for maybe non-inferior, but with intervals that still allow no effect. Adverse events were few and not serious, but they're instructive. Pulmonary exacerbations were 2 in EXACT versus 2 in usual care, and antibiotic treatment for chest symptoms was 4 versus 4. EXACT did show more exercise-related aches, knee, foot, shin, groin, mostly mild, which is exactly the kind of trade-off a pragmatic trial will have to anticipate. Clinically, this doesn't prove that exercise should replace airway clearance. It does something more useful at this stage. It shows the substitution strategy is doable, acceptable, and not obviously dangerous over a month in a carefully selected, stable population. By the time we notice patient ventilator asynchrony, we're often already behind. The patient is uncomfortable, sedation has crept up, gas exchange is drifting, and we start labeling the problem instead of understanding it. This review, published in Intensive Care Medicine in February 2026, is valuable because it pulls asynchrony back to first principles, how pressure, flow, timing, and effort interact, and shows that most asynchronies are predictable once you slow down and read the physiology. At its core, mechanical ventilation is a shared task. The ventilator supplies pressure and flow, but the patient supplies neural drive. Asynchrony happens when those two timelines fail to overlap in a useful way. That mismatch can occur at the start of inspiration, during flow delivery, or at cycle termination, and each phase fails for different physiological reasons. Start with ineffective triggering, the most common and most under-recognized form of asynchrony. For a patient effort to trigger the ventilator, two hurdles must be crossed. First, the patient must overcome any intrinsic PEEP, the pressure left in the lungs at end expiration due to incomplete emptying. Second, the effort must exceed the ventilator's trigger sensitivity. If the patient's inspiratory effort is too weak to clear both, the breath never registers. The ventilator screen looks calm, but the patient has actually breathed and failed. This is where clinicians often misread the situation. The review emphasizes that when ineffective efforts exceed roughly 10% of total respiratory cycles, the ventilator-displayed respiratory rate becomes unreliable. The machine undercounts breaths, and we falsely assume the patient is comfortable or even over-sedated, when in reality they may be working inefficiently. That inefficiency matters. Wasted effort can account for 10 to 50% of total inspiratory work, and repeated failed efforts disrupt sleep, increase dyspnea, and prolong ventilation. The key teaching point is that ineffective efforts arise from two opposite physiological states, and the fix depends entirely on which one you're in. The first state is over-assistance. Here, pressure support is high, tidal volumes are generous, and arterial CO2 drifts down. Respiratory drive falls. Inspiratory efforts become shallow and inconsistent. The review highlights that these patients often have low P0.1 values, less than 3 centimeters of water. P0.1 is the airway occlusion pressure measured 0.1 seconds after the start of inspiration. In simple terms, it's a bedside estimate of respiratory drive. Low P0.1 values signal suppressed drive rather than respiratory distress. In this setting, intrinsic PEEP may only be mild, but the patient simply doesn't generate enough effort to trigger consistently. The solution is not more sedation or higher support, it's less. Gradually reducing pressure support restores drive, strengthens efforts, unmasks hidden ineffective breaths, and paradoxically improves synchrony. The second state is excessive intrinsic PEEP, most commonly in COPD. Here, the problem is not weak effort, but excessive load. These patients have high respiratory drive, often reflected by P0.1 values greater than 5 centimeters of water, yet their inspiratory efforts still fail because they are trying to pull against a large trapped volume. Tidal volumes remain small, acidosis develops, and the patient appears to be fighting the ventilator. The educational pivot here is critical. Applying external PEEP, carefully titrated, can reduce the inspiratory threshold load by counterbalancing intrinsic PEEP. When done thoughtfully, without overshooting, it actually reduces effort, improves triggering, and decreases asynchrony. This is counterintuitive to many clinicians and one of the most useful bedside lessons from the review. The discussion then moves from trigger problems to timing problems, particularly reverse triggering and double cycling. Reverse triggering occurs when a mandatory ventilator breath entrains the patient's neural respiratory rhythm, leading to a diaphragmatic contraction after machine insufflation begins. This is most common early after intubation or during transitions out of deep sedation. The danger isn't the label, it's the consequence. If patient effort stacks onto machine inflation, transpulmonary pressure rises, regional lung stretch increases, and phenomena like pendeluft can amplify injury in heterogeneous lungs. Pendeluft is the movement of air between different regions of the lung, rather than between the lung and the ventilator. What looks like a normal tidal volume on the screen may actually represent excessive regional stress. Double cycling follows a similar logic. If the ventilator cycles to expiration before the patient's neural inspiration has ended, persistent effort can immediately trigger a second breath. The ventilator interprets this as two separate cycles, but physiologically it behaves like one large injurious breath. This week gives you 3 complementary angles on the same core idea. In the ICU, diaphragm neurostimulation might shorten the path to liberation, but the safety signal is real, and the early stop design means we should treat the benefit as provisional. In cystic fibrosis, substituting exercise for airway clearance looks feasible and not obviously harmful over 28 days, but it's still a pilot signal, not a practice change. And the physiology review is the reminder that effort only helps when the timing and load make sense. As always, this is education, not medical advice for individual patients. If this format helps you keep up without drowning, subscribe and share it with someone who's on service with you. Thanks for listening, and I'll see you next week.